We hope you enjoy the next 2 days, and we're very pleased to kick off the conference with a really wonderful panel, which Lucy is going to introduce.
Thank you. Not really a panel, but it's two speakers, and you call that a panel?
It's a panel.
Oh, all right. Okay. We are pleased to have Sheldon Dent, who's standing in for Nancy Bargeman. Well, Sheldon has spoken at this conference before, and he doesn't need to be described as a stand-in. He's a standalone speaker, and he is the Assistant Deputy Director of Programs and Policy Branch for the Department of Developmental Services, has worked with people with disabilities for nearly 40 years, and has been with DDS for, I believe, 31 years. And he will be followed by, on the panel, Eric Ziegman, who is the Executive Director of Golden Gate Regional Center. And I didn't get all that background info on you, Eric, so you have to describe yourself a bit more. And so, not that interesting. Oh, I bet it is. I'll bet it is. So, Mr. Dent, will you come to the podium, please? Welcome back.
Thank you. Thank you. All right. Good morning, everybody. All right. First of all, Nancy Bargeman wanted to make sure that I apologize profusely for her. She sincerely wanted to come to this meeting. She knows that there's a lot of clinicians and such that she doesn't get to speak to very often, so she really wanted to be a part of this. But one of the things that got in the way, but is helpful to all of us, is the budget hearings. So she had to go up to the Senate and to our representatives to talk about our next state budget, and she is doing that and doing a great job of it. Some of you might have saw her on the Cal channel just yesterday talking about budget issues, and that is what called her away. One of the things she asked me to do, and it still says Nancy Bargeman on her presentation because it is her presentation. I'll try to do it justice, but it is what she wanted me to go over for you today. An update on the Developmental Disability Service System. So, I'm also supposed to let you know that I don't have anything to disclose. So, with that said, the Lanterman Developmental Disability Services Act, as you know, it was passed in 1969, and it just celebrated its 50th anniversary. But the biggest thing about this Lanterman Entitlement Act is that it's the only entitlement act of all of the 50 states. So California has the only entitlement to services for people with developmental disabilities. We have a mission statement. We have a vision statement. The mission statement is to ensure that people with developmental disabilities have the ability to live lives just as you and I do. Our mission statement is that, and our vision, building partnerships and supporting choices, is really about a system of partnering with folks so that our system works together as one. It's a system structure for people to work together and agencies to work together and everybody to work together to make services and supports available for people with developmental disabilities. When we look at our system structure, you'll notice that it starts with the governor's office, of course. We have the Health and Human Services Agency, which the Department of Developmental Services is a part of. And then we have state developmental centers, as well as one state-operated community facility, which is run by the state and has state employees. And then we contract with 21 regional centers. Oftentimes, people call the department and ask us to have an issue with the regional center, and they want the Department of Developmental Services to address it immediately. And we oftentimes, unless it has something to do with a violation of law or regulation, we have to refer them back to the regional center because the regional centers are all And a lot of people are surprised by this. The regional centers are all private nonprofit organizations, and they answer to a board of directors. Other than violations of law or regulation, everything else, we can address things that have to do with a violation of law or regulation, but everything else has to go through their regional center director and their board. So one of the big examples that we get is oftentimes vendors might get vendored to serve, like a residential provider might get vendor to serve 6, or get licensed to serve 6 people, and the regional center tells them, we'll vendor you for 4. And they'll call the department and say, I got licensed for 6 people, I want 6 people in my home. The regional center says they'll only give me 4. That is not something that the department can do something about. That is a regional center and their board of directors' decision to serve people in that manner, and that's how regional centers were set up, to do what their local community feels is the most appropriate way to serve folks. So that's not a violation of law or regulation, and when we get calls about that, we refer them back to the regional center because that's the way our system works. The regional centers have case managers that help coordinate services, and they vendor service providers who actually provide direct services and supports to our consumers. And all of that is done through a IPP and a person-centered planning process. So as I said, they contract with these 21 regional centers. The 21 regional centers are private nonprofit. There are 21 regional centers to cover all 56 counties of California. Regional centers work with approximately 45,000 vendors who provide those direct services. And we work with a system of partners, other organizations, stakeholder groups, individuals, families, to implement the vision of the Lanterman Act. So what's been going on the last few years? More than a few years, I guess. From 2002 to 2016, you can see the growth in our consumer population. As of December of 2016, we're serving 304,000 people. When you look at the regional center population, from the smallest regional center, Redwood Coast Regional Center, up at the northern tip of California, versus Inland Regional Center in San Bernardino, you see Redwood Coast serving 3,600 folks, and Inland Regional Center 31,300 folks, with the average regional center serving 14,000 folks. The way this consumer population is growing, essentially, we could start a new regional center every year. Consumer population by age. As we gather this type of information at the department, this is one of the areas where we look at trends to see what's going on and see what kind of resources need to be developed or what kind of legislation might need to be addressed to address some of the trends. One of the things you'll notice here is that our elderly, seniors, are beginning to grow, which tells us that our folks are starting to live a lot longer. One of the things that we've done to address this is we've worked with community care licensing, and you may have noticed this already, but a lot of the community care licensing folks are now starting to allow people to age in place. So folks that are in adult residential facilities can stay in adult residential facilities. They don't have to simply move because they turn 60. Usually the adult residential facilities limit is up to 59 years of age, but community care licensing is working with us, and now for the most part, is allowing people, unless there's some drastic differences between the consumer population, will allow people to stay in adult residential facilities for as long as they choose. Consumer population by living arrangement. As you can see, developmental center population continuing to go down. Less people are living those. Of course, that's because of our initiative to close all of our developmental centers. And as has always been the case, regional centers work hard to support people and their families, so the family home, parent, guardian, still continues to grow, and people continue to live in their family home as long as possible. When we look at the consumer population by diagnosis, another thing that you see, you can clearly see that autism growth continues to climb rapidly. This is not a secret, and we continue to work on developing resources to address those issues. The population of developmental centers and state-operated community facilities. You can see the steep decline that started in 1994. I don't know if people remember the Caulfield years when we were court-ordered to move over 2,000 people out of developmental centers within a 5-year period. That accounts for the steep decline right there in the early years. But ever since that time, there have been laws put in place, and the lack of federal funding for some of our developmental centers, actually for all of our developmental centers at this point, which has caused us to make the initiative to close all of our developmental centers. And now we have less than 1,000 people living in developmental centers. And then we look at a few budget things. And of course, that is also driven by the fact that we are closing our developmental centers. So there's more growth in community services. From 16-17, it was $5.8 billion to community services, and proposed for 17-18 is $6.4 billion. That's an interesting stat by itself because, as she said, I've been in this services for developmental disabilities for almost 40 years, and I remember when the budget for the whole regional center system was less than $20 million. So we're in the billions now, and we're working hard. And the reason that we're able to be in the billions and the reason that we still have an Entitlement Act is the fact that we are able to capture more federal dollars. It is imperative that the department and our service system captures every federal dollar we can get in order to maintain the entitlement provided by the Lanterman Act. As you can see, a little less than 50% of our funds are federal, but as we move from the developmental center systems, moving everybody into the community, we'll have a lot more pressure still to maintain those federal dollars, and the federal government will still be looking at the community in terms of the dollars that are spent for federal funding. So we'll be under the same types of pressures, really, as the developmental centers were. Developmental centers were unable to maintain certification, which is partly what's led to their closure, other than the fact that people shouldn't have to live in state institutions. But the driver of that has to do with they could not maintain their certification, which meant total general fund dollars were going into funding the developmental centers. That same pressure will be on the community because through our home and community-based services waivers, that captures a great deal of federal funding. They'll be out monitoring to make sure we're meeting or complying with the home and federal waiver requirements. And if by chance we're not following those requirements, they will cut federal funding, which is why there's a lot of pressure on regional centers and our service system to capture those federal dollars and be in compliance with federal waivers. So who do we serve? As you can see, the Hispanic community and our white community are the primary drivers. And when we look at who we serve, we also have to be mindful of the unrepresented communities. There's one of the big things that's talked about a lot at the legislature and within the department and within the regional centers now has to do with disparity in services to different ethnic groups. A very interesting issue that's come up with this, and another slide will show you, has to do with, even though white is still the largest, they're starting to go down, and Hispanic is starting to be a large area of growth. However, when you look at the utilization of services, you'll see that Hispanic is not utilizing a lot of the services that are available to them. We find this can be, of course, an issue with culture, but it is something that we want to address, and it's something that the legislature wants to address, as there have also been a lot of complaints about in different regions where the population in Hispanic or Black is high, and yet utilization of services seems to be unequal. So as you can see from this slide, even though Hispanic is high, they only utilize 79% of the services that are authorized. Another interesting thing that we found with the white population, they use 84%, but they also are the largest user of residential services, which is interesting. So what are some of the recent changes that have come about at the department now? I'm sure many of you remember back in 2009 when there were system-wide reductions, how difficult it was to get services for anybody. Now that the budget has started to make a return, we've got a little more funding to our system, we're able to, as you can see, restore early start program, restoration of prior service provider payment reductions, rate increases for specific service types and to provide additional compensation for direct service providers. There's additional funding for a paid internship program and service provider placement incentive funding for competitive integrated employment. And I find this one to be really interesting because when we did statewide stakeholder meetings to talk about how to implement this paid internship program, and the legislature provided $10 million for this program. And as I said earlier, there was the point where we only got $20 million for the entire system, and we were able to get $10 million for this one program. We've come a long ways. And we have additional funding to regional centers to address purchase of service disparities for underserved populations. In fact, we get $11 million annually to address that issue that I just talked about between the different ethnicities. We also received increased funding to address statewide minimum wage increases, increased funding to facilitate development of community resources for individuals transitioning from DCs and to meet challenging service needs. We have increased funding for regional center operations, including reducing caseload ratios and new positions at regional centers. Some of those new positions include a cultural specialist, an employment specialist, and a federal program specialist to, again, ensure that regional centers are able to comply with home and community-based service waiver issues. As I said, those dollars are going to be critical to our system. And then new DDS priorities and initiatives. Of course, one of the reasons Nancy's not here has to do with new legislation and funding. So it's going to be incumbent upon us to operationalize and implement any new legislation and funding. Home and community-based settings, the federal rules are out there for people to review. They're critical for our federal dollars, and we need to be in compliance with the federal home and community-based settings rules by March of 2019. We have new community service models, enhanced behavior support homes. We have adult residential facilities for persons with special health care needs. We have added delayed egress secure perimeter services to our residential programs that's available for folks to use when needed. One of the things I would say about the what is also called our RFISHN, or Adult Residential Facility for Persons with Special Health Care Needs, they are starting to grow rapidly. They have proven to be a very effective and successful service for people that are medically fragile. And in fact, hopefully one of the initiatives might be to spread that program for children that are medically fragile. That's what we're looking at next. We already have, in the past I've talked about the RFISHN program because it was modeled after the program for children, which was previously called Bates Homes. And the RFISHN was modeled after that, but the problem with the Bates home is that they can only be done in small family homes or foster homes. We want to expand that program so it can be done in a group home so that it doesn't have to just be run by the person that owns the home. Then, of course, we have the self-determination program. And I don't know if people know, we've been trying to get this self-determination program off the ground for quite some time. We applied. Actually, we're the only state that had to apply to the federal government for the self-determination program. And we sent our application in way back in 2014, December of 2014. And we're still responding to questions from the federal government to try to get this thing off the ground. And even once we get it off the ground, it's still just supposed to be a 3-year pilot and can serve 2,500 people. But we feel like we're getting a lot closer to answering all their questions, and hopefully we'll get this thing going in a short period of time. One of the things about the self-determination program that people may not know is that people get to direct their own budget. So they'll receive, depending on what their IPP needs are, they'll receive a budget to carry out that on their own, and they can choose their service providers, who they want to get services from, who they want to get their support from. It should be a very interesting program once it gets here. And then again, we want to reduce inequity and disparities in our system. Reporting on regional centers. I don't know if people have looked at our website lately, but we have a dashboard on our website now where a lot of regional center data on individual regional centers can be found. And so you can look at a website and you can look at that dashboard for regional centers and get a lot of data on what that particular regional center is doing. And of course, the developmental center closure and transition activities. There's a great deal of work and activity going on to transition people appropriately from the developmental centers. One of the big complaints during the Caulfield years was that we moved people too fast. I can tell you that that's not the case with the developmental center closures for Fairview, Porterville, and Sonoma, which are the 3 remaining developmental centers. There is a lot of transition activity that goes on with each individual that moves from those developmental centers. And regional centers are doing a great deal of work to develop the appropriate resources for folks and see that they are moved appropriately, and that once they move, the quality of services they provide is appropriate as well. And then we continue to provide community development funds to regional centers to develop resources not only for people coming out of developmental centers, but for people that are in our college hospital, jails, and we still have some consumers that live out of state that we want to bring back to California because we believe California is the most appropriate, and our system was developed to serve people in California. So those folks that had to be placed out of state for one reason or another, regional centers are developing resources so that they can bring them back to California. And with that, are there any questions? Okay.
And table, Mr. Dent, and we can barrage you both
All
with
right.
questions afterwards.
Fantastic.
So, thank you. And so now it's my pleasure to introduce, for the local perspective, as it were, Mr. Eric Zigman, who is the Executive Director of Golden Gate Regional Center. And give us some background on yourself, please, Eric. Welcome.
Thank you. I'm going to get a glass of water. Thank you, Dr. Crane. I didn't want to do that when Shelton was speaking because I knew I would spill it and fall down and stuff. So thanks so much for inviting us to speak today. I feel really honored. This conference has a great reputation, and I know you guys will have a great couple of days with all the sessions that are going on. So I will give you a brief, short biography of me. I started in direct service in 1989 in a sheltered workshop with 110 people with intellectual and developmental disabilities, and we had about 20 folks working in the community. And over 15 years, we shut the sheltered workshop and got 110 people working in the community. This was in Santa Cruz, California. It was outside of the closure of Agnew's Developmental Center and the part I was lucky to play there. The closure of the workshop and moving people into community employment was certainly one of the high water marks of the work I've been involved in. So after that, I played a lot of roles in an organization, like many of the old-timers in the system, including Nancy Bargeman. I had a lot of different roles that hopefully prepared me for the work we're doing now. I was involved in services, in supported employment, and as I said, and in supported living, and in independent living, and in children's respite, and just a broad variety of the provision of services, and learned a lot from the people we served in those years. And then I consulted for 9 years, which was a shock to me. I thought I'd do it for a year, but the work just was so interesting. A lot of it had to do with the closure of Agnew's Developmental Center in the middle of those 9 years, certainly between 2004 and 2009 when Agnew's closed. And that included work to help East Bay group found Alegria Community Living, which is a wonderful provider in the East Bay, all throughout the East Bay. And excuse me, also I was director of the quality management system for the Bay Area project, which was the closure of Agnew's, where we got to see the transformation of folks from living in an institution to living in the community. And I got to see 300 individual stories, really, of the stunning changes in people's lives, that people in their 60s and 70s and 80s and 90s mostly moved out into the community and really got a new lease on life and got to do things, extraordinary sort of transformational things. So. And then the last 3 years prior to me coming to Golden Gate 9 months ago, I was the CEO of the Pomeroy Center, used to be called the Rec Center for the Handicapped, or RCH, a legacy 60-year-old provider in the southwest corner of San Francisco that was a leader in its history in some eras, some decades, around recreation and people with developmental disabilities. And that was a great experience. So now I'm charged with running one of these interesting beasts called regional centers. There's only 21 in the state. Sheldon referenced that we are 501c3 nonprofits, and some of the greatest innovation, some of the highest highs and lowest lows have come from the fact that we are nonprofit organizations. And though we do much of the work of government, we are not government agencies. Not yet, anyway. One thing that's very interesting is, and I've really never completely fact-checked where this came from, but I believe the original design of the regional centers was to add a regional center for every million in population, the general population in California, in which case today we'd have 40 regional centers rather than the 21. And then, as Shelton mentioned, the other way to look at that is just the intakes into the system each year are about 14,000, and that's the size of a medium-sized regional center. So we are taking in about the equivalent of the people we serve in terms of adding a regional center each year. So I am going to figure out how to use these. Forward. All right. So those are my disclosures. No products, no services. I'm not selling anything, but goodwill and civil rights. All right, so here's what I'll try to do in the next 20 minutes or so, and leave some time for questions for Shelton and I. We're going to talk a little bit about the history of the regional centers and the Lanterman Act in particular. Some of this duplicates a little bit of what Sheldon had said, but hopefully gives you a little bit different perspective. I mean, I think this 16th annual conference, really some of the key language around the point is to really look at community living broadly and transforming systems of care and the history of the Lanterman Act really is about sort of transformation of a different kind of approach than the typical government approach to services. And like any system, it falls on hard times at different points and needs renewal. And it feels, hopefully to me, that we're at the beginning of a renewal period with the influx of funding that came into the system this year, and some of the discussions that are going on, and certainly the closure of the institutions. So let us plow on. I always like to quote physicists when we're doing a conference on healthcare. No, I've always been taken by the phrase where we stand on the shoulder of giants, and that was Isaac Newton's phrase about Galileo, I believe. Really, all the work we do is predicated on the work that comes before us, and especially when we talk about civil rights, you've got to be in it for the long haul. So it's really good to know where you came from, and then it's also helpful to know where you're going. But we really do have a 50-year history, and I wanted to kind of put a context to what was happening leading up to the Lanterman Act being passed, and this slide could really be fact-checked. I would like, in my revised version, which is almost better that it's not up here, don't think you're a civil rights expert when you're not. And so I did some of this from memory, and when I really looked on the internet, I was like, well, I got it pretty close. I was thinking I really wanted an organization like New York Times or CNN to really fact-check, so to make sure it's not fake news. Trying to have any fake news. But really, all these things were going on. The Civil Rights Act of 1964, Selma didn't have a bus strike. Montgomery, Alabama had the bus strike, but Selma did have a march, so I got that half right. And then the 1964 Democratic Convention did have a silent vigil for civil rights, which was fascinating, which I guess my mistake led me to more information. But I was really referring to the 1968 Democratic Convention, where it was much less than silent, and there were a lot of advocates, including some people with disabilities, protesting the Vietnam War and other social change things. The March on Washington, the Stonewall riots for, at that time, gay rights, now would be called LGBT rights, the second wave of feminism. I mean, all these things played into the Lanterman Act and the independent living movement. I mean, the Ed Roberts Center is across the bay in Berkeley, and I urge everyone, if they have a chance, to visit it over the Ashby-Bart station. Ed Roberts was a giant in moving things forward for all people with disabilities, and so certainly played a role in that. Judy Heumann, others in that movement. And so that's all that was swirling around during that time in the mid-'60s, when the first pilot project was announced to try regional centers as an alternative to institutional living. And I will say, some of Shelton's data is very powerful to me, especially the chart on the reduction of people in institutions. In 1965, there were 13,500 individuals with intellectual and developmental disabilities in state institutions, and there was waiting lists. That was like, we are full up. There was no room at the end. And by the end of this next fiscal year, we should be under 500. And so that's the object lesson of civil rights change. It takes way longer than you would want, but that is a powerful change in our world and our system. So in the March on Washington, the famous I Have a Dream speech was done by Martin Luther King. And one of the fascinating little side stories is Mahalia Jackson, who's a gospel singer at the time, would often sing before Dr. King's speeches. And he had asked her to sing a particular song before the I Have a Dream speech. And the I Have a Dream speech really didn't have I Have a Dream in it. That was really, he took that extemporaneously, inserted it from one of his other speeches. He hadn't really intended to have that part. And if you watch the YouTube video, my whole theme today is fact-checking me, I think. If you look at the YouTube video of Dr. King's speech, or at least if it has enough quality of sound, you can hear Mahalia Jackson in the background saying, tell him about the dream, Martin. Tell him about the dream. And so he pivots into that section. And it's very powerful for me lately about what role we all play in leadership. Here's this performer who played this kind of seminal role in changing Dr. King's speech or making it this incredibly famous speech. So I just love that. I do love that story, and I did check it out, and it is online. So Dr. King said that he had a dream that his 4 little children would one day live in a world where they were not judged by the color of their skin, but by the content of their character. And I think, the Lanterman Act really, for people with intellectual and developmental disabilities in California, certainly was the launch of that kind of idea that people would be looked at as people first. So I wanted to take a moment before I delve into the Lanterman Act to just talk about identity and disability and the importance of language. I'm not really, I almost said language Nazi, that's not really probably a good thing to say. I'm not really a stickler on language. I would like behavior and actions to really speak louder than language. But in this case, it really made an impression on me as I learned people first language and the difference between saying a disabled person or an autistic person and a person with autism or a person with a disability. The importance there is it sets the individual and the individual's identity at the core of explaining themselves. And so it's a change from saying that the adjective, the modifier, is the important thing about the person, that they're defined by their deficits. And it moves it to saying, I'm a human being that whatever challenges I have in life and whatever special gifts and talents, that informs my identity. But that's not the sum total of my identity. People don't say I'm a glasses-wearing person as like a person who wears glasses. So that's really important to me. It connects to the Dr. King quote that it's about the individual's identity, and that it's, and we all know this, the more you work with an individual, the less you see them as your first impression, and the more you see them as the sort of the core identity of who they are, that's informed by their life experience and sometimes by their disabilities. So I want to go a little bit deeper into the Lanterman Act promise. It's really the promise of equal access, and it's a promise of support. People hear the word entitlement and they think of preference and preferential treatment, and it's important to bring them back really to a civil rights framed for me and say it's about equal access. It's about leveling the playing field. It's about letting people live, work, and play and have an access to that as people without disabilities have access to it. It's not about any special quote-unquote treatment. I'm going to move, I think, quickly through these slides somewhat, but the first page of the Lanterman Act is like the Declaration of Independence for the country. It's really well written. Art Bolton was a staffer for Frank Lanterman and others, but Art really played a huge role in drafting this language. And it says right at the beginning that the state of California accepts a responsibility for persons with developmental disabilities and an obligation to them that it must discharge. It affects hundreds of thousands of children and adults directly, and I love this part, and having an important impact on the lives of their families, neighbors, and entire communities. Developmental disabilities present social, medical, economic, legal, I would say issues now. They said problems in 1969 of extreme importance. So what did it really do? All of this is contained again in that first page of the Lanterman Act, the first 4501 of Welfare and Institutions Code. It created an entitlement. The entitlement really got rolling in 1985 when the ARC of California sued the DDS, brought a case that went to the state Supreme Court, and the 1985 state Supreme Court decision basically says, yes, that obligation means you have an obligation both to fund the system, and if the system runs out of money, the Department of Developmental Services, Shelton's going to go back to the legislature and ask for more money. When it runs out of money, that was the original intent in the Supreme Court decision. And that Department of Developmental services would have somewhat limited influence on regional centers. That at the service level, the IPP, the individual program plan, as Shelton referenced, would be the driver of services, and the regional centers would be responsible to their communities to provide services in the way that best met those needs in the IPP. And the Department of Developmental Services would play a funding role and a legal role, but not direct regional centers in what to do. And that really is where the flexibility in the system has come from, and the ability to innovate in a way that we could have never done over 50 years if we were state-owned and operated. No offense, Sheldon. It also established the IPP, which is one of my mentors who's passed away last year, Barbara Mazie of Contra Costa ARC, used to just hammer about the IPP being the legal source document. It all comes from the IPP. But it's true. That's how we plan one person at a time and don't have cookie-cutter, one-size-fits-all services. We have services that are responsive to the individual. The other things the Lanterman Act right away does is have this great language around establishing an array of services based on needs and choices, and that it'll be regardless of age and regardless of degree of disability, which was a very important thing. And it sometimes gets in the way when we're trying to explain to legislators, especially new legislators, and give them an idea of the people we serve. It's really helpful to bring a vast variety of the people we serve, because it's hard if you haven't had an experience of intellectual and developmental disability in your family or neighborhood or friends to really be able to talk about just the vast diversity and difference and different presenting needs and different ways of communicating that's represented by the people we serve. And then this great phrase of integration into the mainstream life of the community. Who knew the community even had a mainstream life? But it does, and we're still kind of chasing that goal. And then another phrase that's an awesome phrase is that, and again, it relates to equal access, not preferential treatment. The whole system is to help people with intellectual and developmental disabilities approximate the patterns of everyday living available to people without disabilities. And now we're seeing that language echoed in the HCBS Final Rule, new federal expectations or current federal expectations that we have to comply with, that all the country has to comply with by March of 2019. But it was right there in the Lanterman Act. And this great phrase that, we really want to pursue people. No, we're not pursuing them. They're coming to us. We really want to help people pursue their own personal futures. And for me, that I always like to think of that as, we're here to help people have equal access by meeting their needs, but also by helping them define and meet their aspirations. It's not just all about sort of Maslow's lowest levels of meeting needs. It's also about higher level aspirations that we are charged with supporting people in. Okay, so that's a Lanterman Act Crip Notes version. Like the Civil Rights Act of 1964 and the the National Supreme Court decision of Brown versus Board of Education, in our country, in our culture, we often pass laws and then we have to have court cases that come along behind and enforce the law. And when I went to graduate school at another university here in San Francisco, I got to be with people who provided services or in management and leadership from disability services from all over the country, and a couple from Finland. And we had two women, Helena and Tina, who were doing disability services in Finland. And when we went through this section on all the Civil Rights Act, Brown versus Board of Education, one of them raised their hands. I remember it was probably Tina, not Helena. And she said, wait, why did you need to have the court case to enforce the law? Why didn't the people in your country just follow the law when you passed the law? We all looked at each other from the United States and went, "You must not be from here." It's a very European, especially Northern European thing. You pass the law, so you follow the law. So that happened with the Lanterman Act. I mean, it was in place and it was chugging along, but it was really that 1985 state Supreme Court decision that said, no, this is true. This is, you got to put your money where your mouth is, California. You got to fund this system, and it has to be based on individual need, not categories of cookie cutter services. So now we get into the healthcare within a social justice frame. So, and I learned this mostly from my friends and colleagues in that USF program, in the disability rights movement, sort of writ large. The people with physical disabilities in particular were very uncomfortable with the medical model. And I remember when we were closing Agnew's, we had a great RN who may be here today, who didn't come from the field and said, "Why do you keep saying medical model like it's a negative thing? Like, we in medicine think medical model kind of makes sense." But for people with disabilities, the medical model really translated into a disempowering model in our history, where the physician would diagnose that the person was basically broken and needed to be fixed in various different ways, and would prescribe things to help them get better and fix them. But what's even more kind of damaging was that we as human service professionals took on this quasi-medical model, where we were diagnosing that if Eric just would bathe more, Eric would be better, regardless of what Eric wanted to do. And so we kind of, diagnosed folks in the early days about what they needed to get a job in the community, for instance. And it, not only was disempowering and robbed people of their agency, but it also wasn't effective. We had folks who, would have to be in workshops for years and years and years to be able to get a chance to have a job in the community, when if we found somebody who really was interested in working in a hospital, instead of having a grooming goal and hammering on them of what normal grooming was, we would take them to the hospital and say, "If you want to work here, you're going to have to take a shower, man." So that's a huge change, and I think we're still undergoing that change in our history. Some disability rights advocates that I was with about 2 years ago, with autism, we're talking about internalized ableism, which is a fascinating sort of idea that they had to overcome in their own lives, this idea that they weren't working hard enough to be able to pass for somebody without a disability, and they internalized that, and it had robbed them of some of their power. So one of the things I have at the end in one of the web links is the Disability Rights Education Defense Fund, DREDF. They have this healthcare stories website, and if you think this is only in the past, this damage of that approach, prescriptive approach to people, there are all kinds of folks with disabilities who are on that website talking about their experience with the healthcare professionals, and it's fascinating. Our clients, our consumer rights advocate, no wait, we're dropping that language, Elizabeth Grigsby, who's a great advocate for us at Golden Gate. I think we're just saying advocate. That's what I'm proposing to have her title be. She's on one of the stories, and they're all compelling. So I urge you to look at that. So that was our past. Where is our trajectory? Where are we headed in the future? It's really, and we're kind of in the middle of this, from the medical model to a person-centered thinking model, or a nothing about us without us model. Golden Gate's been a leader along with Redwood Coast Regional Center and Tri-Counties Regional Center. We've attempted to be a leader in person-centered thinking. It's a whole sort of way to approach planning that really puts the individual served at the primacy in the place that the Lanterman Act says they should be. And one of the more powerful, simple tools is just to help folks who are facilitating those meetings understand the difference between what's important for someone, which is sort of relates to all the prescriptive things we know as professionals that will help somebody in their lives, but then to differentiate what's important for someone from what's important to them, so that there's a space cleared for them to be able to clarify that to the group in some ways, or the people around them, if they're not able to articulate what's important to them, help really clarify what their aspirations are, where they're aspiring to be and where they thrive. So what does healthcare within a social justice frame mean? It means for me that individuals get to be experts about themselves. I've already talked a lot about needs and aspirations, and that we listen to the people we serve. One of the best things about the organization Skills Center that I cut my teeth in, or started out in that sheltered workshop in 1989 was that part of their core values was simply to listen to folks, and listening is a huge part of leadership, and it's served me well in this work. And so, at 10:15, following Lachelle and I, there's a seminar on when listening is complicated, so it really relates to that, and I'm sure we'll all learn from that seminar as well. Okay, now I'm way over time, so I'm going to move through quickly. I talked about the healthcare stories, the intersection of developmental disabilities and mental health and dual diagnosis and the services is way longer than this lecture, but I think it is really a core sort of area that we're going to have to improve in the future. So where are we now, and what are we building towards in the future? The scale is just amazing, and if you haven't a chance to look up We Are Here to Speak for Justice, it is another historical piece. I swear this is the last history lesson I'll give. But if you look at that first paragraph and assume that it was divided equally between the first two regional centers in 1966, then Golden Gate probably had 275 individuals served or so and had a budget of about $500,000. Today we serve almost 9,000 people and our budget is $284 million. So as Shelton said, that it has really changed over time. The world we're in now is a world without developmental centers. It really is now because it's so very difficult to get anyone in, which is great from a civil rights perspective. It creates some challenges for regional centers to make sure we can serve everyone in the community. Sonoma Developmental Center, as some folks in this room are keenly aware, is closing December 31st, 2018 is a deadline set by the state. And our Golden Gate has 67 individuals that we do the case management for, of the about 300 now living in Sonoma. And so we are very focused on moving them into the community as soon and as safely as possible. And there's lots of political pressure around this, both from the legislature, the federal government, the department. But that's not the reason we're doing it. The reason we're doing it is we believe they'll have either anything from incrementally better lives to stunningly better lives, and mostly on the stunningly better lives side of it. And so I think we owe it to the 67 souls that are in Sonoma that we have responsibility for to move swiftly. I'm not going to tell the Agnew story again, that's too long, other than to say I met recently with our great Director of Clinical Services, Dr. Lynn, with the San Mateo Health Plan, the Health Plan of San Mateo, and with the Puente Clinic down there. Those were both partnership. We partnered with both of those entities, and the Puente Clinic was sort of created during the closure of Agnew's, and it's really gratifying to see resources that came through the only startup money that was available since 2003 has been for developmental center closures, and these resources really have both grown and helped our capacity in the community, and we hope to do more with them. The challenge for us now is really, and Director Bargeman of the Department of Developmental Services is very clear on this, and this, I wonder if I say Director Bargeman, it'll chirp every time. Nancy's just watching me. she's very great in many, many ways in terms of her vision for the future, but she's focused on the building of a safety net in the community, because without developmental centers, we need that. I'm not going to talk about the CMS Final Rule. There's a ton to talk about in that. So I'm going to skip that slide, and then really wanted to talk a second about housing as a component of health. There's been some studies in Hawaii, and I know our partner nonprofit that develops housing, Brilliant Corners, is doing some other work with the health plan of San Mateo that really talks about how powerful housing is in terms of impacting health. And the Hawaii study actually put dollars to it and showed that it was a cost savings to the state to house people rather than to have emergency rooms be flooded with individuals. The disparity projects connected to what Shelton was talking about with the disparity of purchase of service dollars in underserved ethnic communities is really powerful. We're starting a couple projects in Golden Gate, one with support for families in San Francisco, and then expanding to Marin and San Mateo counties that are going to try to have cultural brokers go into underserved communities from those, hiring from those communities. They're called promotoras also, to help connect families to our services and have them use more of the services that they get authorized to use. Dr. Rubin has a social and cultural determinants of developmental disabilities that relates to that, a session coming up today at 3:30. And then the self-determination is going to be really large. And for this group, folks are going to be able to have a much broader choice, the intent is, of what services to purchase. And so for healthcare, that might mean alternative services, acupuncture, chiropractic, herbal medicine, and that'll have an interesting impact, I think, on your community. The two of the models that are happening that are exciting in Golden Gate's area, the ARC of San Francisco has a healthcare advocacy program that I became really aware of when I was working at the Pomeroy Center, because we were able to kind of partner with them on some assessments, and it really plays a role to help advocate and coordinate healthcare for folks living on their own or in the family home, and we found it really to be powerful. Okay, now I'm speeding along. I just wanted to end with talking about Golden Gate. We're going through a strategic planning process, and these are all the areas of task force that my predecessor, Jim Shorter, has put together that is giving recommendations to our board for a 3-year strategic plan in terms of how we're going to make decisions about investments and resources in terms of strengthening the system here at Golden Gate. In that, Dr. Clarissa Kripke of UCSF and our clinical director, Ingrid Lynn, were able to put together recommendations with a task force for the regional center, and those recommendations are, have detail to them in the plan, and we can share that if you're interested, but really are around these 4 areas, and they're all extremely important areas to try to strengthen healthcare for the people we serve. I did want to mention, I didn't talk about the CART model in the last slide, but that is a model now that Dr. Kripke has been working on for years and is now really launching with a number of regional centers, including Golden Gate, to try to bring consultation to homes and training to homes around particular individuals in nursing and psychiatry and psychology, and with parent sort of support expert, family support experts. And we are really looking forward to having that help expand our capacity and make our services of higher quality. I'll end just by referring back to Martin Luther King one more time. He says the arc, and this is up a lot on places, the arc of the moral universe is long, but it bends towards justice. So the fact that we're a 50-year-old system and we're still dealing with some issues shouldn't discourage us. There's plenty of evidence that these changes take decades and sometimes centuries, and we're in it for the long haul. So thank you very much.